Hi GP learners, and thank you for joining me on this Monday evening. And I'm honoured to have Dr. Tricia Greenhalgh with me as we talk to you about video consultation skills and how we can help you do this in our current coronavirus environment. So let's tech enhance your primary care and learning. If this is the first time we're meeting, I'm Dr. Gandalf of VGP Learning, where I look at supporting you with technology-enhanced primary care and learning. And in this episode, I'm basically going to talk to you about how we can use different types of video consultation skills effectively to help our patients. And this is mainly because obviously many clinicians right now are having to shift from providing face-to-face care to remote digital care, whether that's through telephone or through video consultations. As I said, I'm really honoured to have Dr. Tricia Greenhalgh, who's also on the screen, and hopefully you can hear her potentially if this works okay.
Hello. Nice to be here. Thanks for inviting me.
So just to start off with, what we're going to do is just go through some simple consultation skills, and then I'm going to pass over to Dr. Greenhalgh effectively to talk about the evidence behind video consultations, and particularly with the shift that we've got, because most of the evidence we have is not really around what's currently happening today. I apologise if this goes slightly fuzzy at times, everybody, because we are effectively trying to do this on the hook, and my data is a little bit fun, and there will be time for questions later on, so I will go through the questions and stuff shortly afterwards. But effectively what we wanted to go through was the simple video consultation skills that many clinicians may need to know. I think it's important to remember when we're looking at video consultations, there is still a setup process. I know many people and practices have kind of rocketed through this over the past couple of days, but there are a few things that definitely worth considering before you start doing video consultations. I'm going to not specifically talk about the data side of things, but I am going to talk more about effectively... Sorry, I've got to sign that. Not going to specifically talk about the data security side of stuff because there's a lot more people that are more eligible to talk about that, but effectively the processes in practice. So first thing worth considering is what exactly is useful to do as a video consultation and what is not. I have a general rule of thumb that anything that you can probably do over a telephone consultation, you could probably do as a video consultation. That's not to say that you should, but you could. So that's normally a good marker, I say, to most admin staff and patients as well. I think there are certain consultations that lend themselves to video consultations a little bit more effectively. That's particularly things like skin and dermatology based ones, although you do need to be cautious about the definitions of those. Mental health consultations, because it does allow a potential empathic connection that's better than telephone based. And some musculoskeletal stuff as well, because you can see the patient. Obviously, many people will be looking at how we do this from an urgent care point of view because of coronavirus and the kind of shift that we've had. And we're going to talk briefly about that in a little bit later. It's important you've got the right equipment, so definitely looking at the hardware that you've got and the software. So there are a variety of different software systems out there. Personally, I think there's some really good ones, things like QDoctors and Accurix are two that I would really recommend people looking at. But whatever system you use as a software, you just need to make sure it integrates well with the systems you've got and it's easy to use, both for you and for patients. When we talk about the hardware, well, you need a computer of some sort. So I've got my spare laptop here. It's off at the moment, but you kind of obviously need some sort of interface along those lines, and then ideally another one that has this clinical system that you're documenting on, because often the clinical system and the video system may not be the same thing. There's a variety of reasons why that may be. Often it's because the providers haven't got quite up to speed, although interesting to note, the System 1, as of today, have released their AirMid system that integrates video consultations within them. Another piece of kit that you will definitely need is a webcam or a video interface of some sort. Now that could be a mobile phone, like this, or it could be a webcam, like this. I'm a big fan of using separate webcams, mainly because you can direct them, so you can put them either hanging off your desktop or laptop screen, or you can use a stand, as you can see I have here, that you can place for more effective use. And that's for things like background and also orientation around yourself. The other benefit is they tend to have a separate microphone, which gives you much better audio than the inbuilt microphones that's in most laptops and stuff. Obviously, most desktops don't have a webcam or a microphone involved, so it's important to recognise those differences. Next consideration is how you're going to be doing the video consultations, so whether they're going to be on-site, for example, within your own practice, or whether they're going to be remotely based. Again, this is something many people are going to be looking at over the next few days, but recognising how that's going to work and the data connections and all the aspects along those lines are important. I think one thing we will see is more and more practices looking at providing remote consultations through hubs, potentially. We shall see. From a governance point of view, it's important to have things like your policies and your protocols and workflows all set out beforehand and at least consider them. I know many people are rushing to deliver these, but make sure you've thought about how things are going to work within your practice, how the workflow is going to work from outcomes from if you need to see a patient, if you need to arrange results for a patient, if you need to send the patient something, for example, how is that all going to work? And try and have it so that your video consultation clinics are a block rather than interspersed between other things, because shifting from face-to-face to video to telephone back and forth regularly, it's a massive time sink and it's not something I would recommend people consider doing. Important to also recognise how you're going to manage interruptions. I'm sure many people have seen the BBC video of the specialist that kind of had his child running into the background. Now we would kind of hope that doesn't happen in practice. May do, you never know. But also in the home environment, if you are working remotely, how are you going to manage interruptions and stuff? Is there a mechanism that you've got in place? Ideally, having your phone switched off is always a good one, but what if you still need contact? You need to think about how you're going to manage that. And then obviously another outcome that needs to be considered is how you're going to convert a video consultation into another type of consultation. So whether it's going to be video to telephone, video to face-to-face, or video to referral to hospital. How is that going to work in terms of workflow for yourself and for the patient? So important you consider those aspects before you switch go in terms of delivering video consultations. And lastly, as with any form of tech, make sure you test it out first. Because as we all know, tech has a nasty habit of going wrong when you don't want it to, as hopefully none of you are seeing right now, but it's worth having a test both with patients, both with staff, and yourself to make sure you're comfortable with the equipment and stuff. But what about the consultations themselves? Well, when you actually start doing a video consultation, there's various different things you do need to consider. So, as I mentioned earlier, making sure the consultation is right to be done in video. As I said, telephone consultations naturally lend themselves to becoming video consultations, but there are clearly cohorts of patients where a video consultation may not be the best outcome despite the issues. These are potentially patients with learning disabilities, potentially confused patients, patients of non-English speaking, because if you can only speak in English, how much extra value are you going to get? Obviously, one of the key things many people are looking at right now is managing urgent care, and this is particularly in terms of where video consultations does lend itself to some benefit in the fact that it doesn't require you to be in the same room. And when we're concerned about contracting things like coronavirus, yeah, that potentially may work. But still, it's recognising that there are going to be massive cohorts of patients that may struggle to do this, so understanding that. Next is making sure your room's set up appropriately and that you've tested all the equipment. So, for example, checking things like the background, definitely important, but also have you got the right environment to do a video consultation? Is the aircon on, which will inhibit the sound, for example? That's one thing to always remember and consider. And again, how you're going to manage distractions if you're on call for the practice, if you need to be notified for something through what's going on else in the practice and stuff, how is that going to come through to you? Clinical system, for example. Your appearance is something you need to think about because you're now visual. Unlike a telephone consultation, triage clinic and stuff, the patient can't see you. So what they can see when they're looking at you is important. Quick couple of tips. Don't wear flashy clothes. So I've got a rather stripy shirt, as some of you can see. If I wasn't wearing this jumper on top, actually the lines and the visual aspects of things may make it a little bit uncomfortable for you. Worst case, you could trigger a migraine in some people. It's happened. But other things are trying to keep your posture. So I'm slightly hunched over to try and deliver this to you, but that's not really how you want to deliver a video consultation, for example, with a patient. You want to be sat upright, good posture, all these kind of things that show confidence and comfort as well. And also the background. So if I had a big, huge light right behind me, you would find it quite difficult to look at me and to see things. And that potentially may be an issue if you've got big windows in your practice or where the light sources is coming from. And also just making sure there's nothing in the background that you don't want patients to see. Stuff like patient identifiable information like notes and stuff, or urine bottles. Good one to think about. During the consultation, well, what do we need to consider? I like to call this the 2 Ds and the 2 Es. So during, you've got your detail that you need to think about. So when you start the consultation, first of all, checking you've got a good connection, but then something I call grid. So your groundwork, your review, and your ID check. So the groundwork is like many consultations, just checking the notes beforehand so you have a rough idea of what the actual consultation is going to be around, and reviewing the information you already have. So often most video consultations you will have some pre-information, whether that's been done by initial triage from the reception team or whether it's been nominated by the patient in terms of what they've suggested. And particularly with our current coronavirus issue, things like potentially have infection, temperatures, cough, that kind of stuff, that's information that may be relevant. How is that relevant to the patient that you're talking to? Next is the ID check, and this is valuable and important to consider. So 3 points of ID as standard I would recommend. So name, date of birth and address are a good one to consider, but there could be other things you may want to check, for example like email address or other kind of information and things. The next part is also then a privacy check. So because you are now dealing with patients that may be having a video consultation, also them being aware of their surroundings is really important, and making sure they are somewhere safe and private to talk about their health. So my standard question I would tend to do is, are you somewhere private that we can talk about your health comfortably? It's also worth bearing in mind there may be other people around that the patient is happy to have around, but you may not be aware of. Clearly understandable with children, for example, but other people that are behind the camera that you can't see. Worth always asking, is there anybody else in the room? That can be useful. Elderly patients, for example, in terms of assisting you with some parts of examination and stuff, that can be useful information to have and worth checking beforehand. And I know there are some anxieties about clinicians worried that patients may record the consultations. To a good degree, they've got the right to. But it's also, that's one way of trying to help to understand what is effectively going on. In terms of other kind of things, picking up visual cues from the patients is always going to be important. So why is that? Well, there's different ways you can pick up visual cues and things. The way the patient's sitting, their posture, the rate that they're breathing. These are all things that you can pick up effectively by looking at how the patient's talking and stuff. So being aware of that. And also the environment. One of the main reasons why many clinicians like home visits is you get to see the patient in their own environment. And actually, with video consultations, you can do that. You get a window into what the patient's home life is like and what kind of environment they're currently in. Now, it may be different if they're at work, because that can happen, but it's useful information nonetheless. Second is document. So when we're documenting consultations, it's important to remember there's various different ways you can document them. One tip I give to many people is to have a headset. This is partly for a couple of reasons. One, it tends to give you better audio if you are using a microphone. Secondly, it also helps to reduce the stuff that you can hear and you can focus on what the patient's telling you. The additional reason is that you don't hear the keyboards as much when you're typing, and that can sometimes be an inhibition for people to actually document whilst they're having the consultation, which is not necessarily a bad thing because it means the consultation flow is better from your perspective. If you are going to do that though, it's also important to explain to the patient why you're doing that so that they don't get this sense that you're not engaging with them effectively and clearly. Another tip when it comes to documentation, have things like auto consultations or templates or macros or whatever you call them in your practice, but to help speed up the process. So for example, in our coronavirus environment, having a quick auto consultation that this video consultation was done via video due to the current coronavirus outbreak. Also having other ones like checked ID and what you've checked, for example, and various other things like referred for appointment at the practice, a quick little auto consultation that has that information for you. As long as these are personalised to yourself and something that you would recommend using, and there's definitely a probity aspect on there, making sure you have said what you're documenting you said, it's fine though. And then the last E is empathy. And the reason why I say this is that one tip that I always give to people is to try and look at the camera. Now, this is a skill. This is not something that's easily done. And I think if you're starting doing video consultations, this is not something I would recommend you focus on. But if you are trying to have a good quality connection and rapport with patients, actually looking at the camera rather than looking at the screen is a really good tip of trying to enable that to happen. And the example I'll give you is if you've ever had a WhatsApp consultation with your friends or family, discussion over WhatsApp or video, often you don't tend to catch their eye as much because they're looking at the screen and you're looking at the screen and you don't really look at each other. And that sometimes just means that you just carry on doing your normal daily stuff whilst you're talking and just flash at the video when you kind of want to or need to. However, when you're consulting, and particularly things like mental health consultations, actually looking directly at the camera aperture rather than the screen can be really valuable. And one reason why I recommend having a stand is that supports the ability for you to do that. So if you do have desktops and stuff, actually what I would do, if this was my screen, I'd have the camera there. Patient can't see it, they see from here forward, but then I'm looking at them and the screen in the background. That's why I like having a separate stand and stuff. And again, the audio is a little bit better if you're just using the webcam rather than a headset and stuff. The other benefit of having empathy is that you can actually say to a patient, show me what you're talking about. So if they're concerned about their joint or muscle, you can actually ask them to show you what they're experiencing. And that's a real powerful thing that you don't get over telephone consultations. So useful to remember that that's a powerful mechanic that you can use. And then it comes to ending the consultation. So this is slightly interesting. The first thing I would always recommend that you do is confirm the outcomes that you've got. There are clearly consultation skills in terms of summarising and repeating and those kind of things that I would recommend anybody does when doing a consultation over a digital interface, whether that's telephone or video. But just make sure you have confirmed what you've talked about and what the outcomes are going to be. You then need to get the information potentially to the patient if it's a prescription or if it's a request for investigations or if it's simple just patient information. And how are you going to do that? We have developing systems that allow this to happen via, for example, SMS mechanisms, or it could be leaving it a place for the patient to collect. Clearly, having the electronic prescription service effective at this point is really useful for prescriptions and things. And also then clarifying the follow-up and the route of that follow-up. Is that going to be another video consultation at some point in the near future? Is that going to be safety netted information in terms of outcomes going to hospital or other kind of things? Or is it just going to be, let's see how we go? But it's important to have that clear and understanding in terms of how that will work for you. And then it's important to remember to close the call and to close it in a way that feels natural, not forced. Because actually we've got a change in dynamic. Normally patients leave our consultation rooms and that's the end of the consultation, whether that's us opening the door or something else. Well, actually this is different and we're now pressing an off button and we're gone. And you don't want to leave the patient feeling that it's just been cut off. That can be useful if you've got an aggressive patient. We'd hope that's not the case. But actually, this is a change in dynamic that many clinicians are going to have to think about how they do that and to make sure that patients have an enjoyment from the consultation to a degree that they may want to consider using it again, particularly in our coronavirus environment. And that's where you talk about satisfaction. Is it good for you? Is it good for the patient? Important to recognise that and look at that. There is always the administration stuff that comes after a consultation, whether that's referral work, follow-up, all that kind of stuff that needs reviewing and things. And then finally, are you ready for the next one? Well, a good way of checking that is to do some sort of training and debriefing aspect of things within your own practice, whether that's comparing notes with other people, and particularly for those people that are starting to do this fresh, that have never done this before, I would really recommend, at the very least in the next couple of weeks, regularly having a bit of a debrief with others about how the video consultations went, how you felt they could have been improved, just so that you've got some feedback and some peer networking in terms of how this can work. Powerful things like Twitter can be useful. Obviously, stay away from patient information and stuff, but that can be a really powerful mechanism to talk about the consultation that you've had and how you can improve both for yourself and for your patients and for the practice and stuff. So that's basically all I wanted to talk about. If you did want some extra tips, I've got some extra videos that you're more than welcome to have a look at. So I've got my top 5 tips video that talks about video consultation things, as well as information for patients in terms of how to look at video consultations and stuff. Hopefully you've all seen that, and in terms of then being able to use that, it can be effective and things. I have also done a video that had Dr. Helen Atherton, who's a PhD person, apologies for the name, over in Birmingham, and done lots of work in terms of evidence for video consultations. However, what I'm really appreciative of having, and I'm just going to turn my screen over so we can go to her, is having there we are. So we've got Dr. Tricia Green-Haug with us as well to talk about the evidence of video consultations. And specifically, one of the key reasons I wanted her to join us today is simply because one of the things we don't have is evidence for acute video consultations in our current environment. All the evidence that Dr. Atherton talks about in hers is about more the routine kind of reviews, chronic disease management, all that kind of stuff. Well, actually, that's different for today. So wanting to have a look at this basically, and hopefully you can all hear her clearly and effectively. We shall see. Are you there?
Hello?
I think we can hear you. I'm hoping we can hear you.
You just faded out. So I've killed my video, but I'm still there. It just says Iris Research Group as my Zoom name. But I think I'll stay. Let me try the video again. Okay, let me try it. So you can hear me now, can you?
I can hear you, and I'm hoping if I can hear you, then everybody else can. I'm just going to check that.
So shall I give you a quick spiel on the evidence base for video consultations? I mean, as you say, that there's almost nothing that's relevant to the kind of situation that we are going to be using video for over the next few weeks to deal with the COVID outbreak. So I've been working with NHS Digital and with the Royal College of GPs and with various others to try and get guidance and protocols and algorithms put together, but actually the evidence base for any of this is just non-existent. So we're going to be trying to collect that kind of data. Fortunately, we've already got ethics approval for looking at video consultations, which is kind of lucky. But the evidence that's already published, I'll tell you a little bit about the randomized trials, and I'll tell you a little bit about the qualitative research that my team have been doing. So I think there's a few hundred randomized controlled trials, and all of them are really the same design. Somebody who's running a clinic, usually in secondary care, decides to randomize their patients to either carrying on coming to clinic or having a video consultation. And of course, they're going to err on the side of caution. They're not going to pick anybody who's particularly high risk. So it's often the chronic stable, someone described them as the steady eddies, who are coming back to clinic every 3 or 6 months. And people think, oh, you could just see these people by video. And guess what? The results of those randomized trials show that nobody dies, nothing terrible happens. Patients are quite satisfied because they don't have to find anywhere to park at the hospital, all that kind of thing. And there's no difference in outcome. There's no difference in service usage, and there's not a lot of money gets saved because you're not really measuring patient-borne costs unless you live on some island off the coast of Scotland, in which case that does become a patient-borne cost for the NHS. But assuming you don't, the economics of video consultations, it doesn't really save that much money. Now that's the RCTs of chronic, stable conditions, and it's the same for haematology and gastroenterology, and it's also the same for some primary care follow-ups. Now, what my team were doing was looking qualitatively. So we used video and also screen capture. So we'd have 2 researchers, one goes to the patient's house and one stays in clinic, and we'd have 2 video streams from each of those sites. We have 4 streams of video in total. So one video is sited, video camera is sited the other side of the room to capture what's, the background and for example, the patient's living room or the nurse's clinic or whatever, doctor's clinic. And the other is a screen capture video that captures what's on the screen. And so what you can then do is join those 4 streams together, and then you can have quite a lot of fun watching the video of the doctor and the patient and what each of them is seeing on the screen. And we've been very fortunate to have enough funding to look at about 50 of these consultations in micro detail, typing out every last cough and intonation and overlapping speech, and analysing them in great detail. And so you don't have to read the papers, because I know any of you have time. The bottom line is that the very beginning of the consultation and the very end of the consultation are very different to what happens in a face-to-face clinic. I should have said we've audio recorded face-to-face clinics for the same conditions and is almost identical, apart from the fact, obviously, that you can't listen to someone's chest. But if you just look at the conversations that happen and a visual inspection of something like a rash or whatever, then it's exactly the same. So what happens at the beginning and the end of a consultation? Well, very interestingly, at the beginning, it's just like anybody else connecting by Skype or FaceTime. There's a bit of faffing around for about 15, 20, 30 seconds where somebody says, can you hear me? Can you see me? Often shouting into the camera, fiddling around, bits of missed audio where people haven't got their sound adjusted. And then something very interesting happens, and we've seen this. It's like when you're listening to a piece of music, when they change from a major to a minor key or vice versa. At some point, usually the doctor, but occasionally the patient, says something, and then both of them drop into role. The doctor starts being a doctor and the patient starts being a patient. Until that time, they're just 2 random dudes trying to connect. So once they've connected, everything goes, oh, right, what can I do for you today? Oh, it's my such and such problem, doctor. And then, towards the end of the consultation, achieving closure is again a little bit different, not quite so dramatically different. But I interviewed a patient a few weeks ago, and I observed the consultation. I didn't find anything wrong with it. I thought the doctor did fine. But I was sitting with the patient, and I said, "What did you think of that?" And the patient said, "Well, he was very rude. He hung up on me." And I thought, well, he didn't really. He just sort of hit the little red telephone and stopped. But the ritual of getting up, walking to the door, opening the door, showing the patient out hadn't existed. And so I fed back to the doctor. I said, look, you're going to have to be a bit more emphatic to say, right, that's the end of the consultation. It's been lovely talking to you. I can see that you're all right, and we'll send your prescription. I'm now going to say goodbye, and I'm going to hit the button, and that's the end of the consultation. So really go through a bit like you're taking a driving test to make sure the closure of the consultation is nicely achieved. What else did we find in our research? Well, the other thing we found, which is very relevant to all you people who are trying to set up video consultations, is it's jolly difficult. It's not just the same as, the very first time you ever tried to use Skype or FaceTime, where you fiddle about and you can do it. After 5 minutes, you've worked out how to do it and you're connected. When you're trying to introduce video into an organization, you come up with information governance, you come up with procedures, protocols, you come up with the fact that things have got to be signed off by all the partners. And it's those kind of what we call infrastructural problems. And we've just written a paper, I just published it in the Journal of Medical Internet Research, called Infrastructure Revisited, because people were writing about infrastructure 20 years ago, but we haven't solved it yet. It's more the infrastructural problems than the technical problems when you're trying to get set up. Now, there's not many.
Dr. Greenhalgh, if I could just stop you for a second.
Pandemic, but one of them is going to be that suddenly some of those infrastructural problems are going to be cut through. They're going to get rid of the red tape and say, yeah, all right. The CQC has said from today we're not doing any inspections. All sorts of things are coming out from NHS England saying we understand we're in a crisis situation. What that means is you will probably able to get that piece of software downloaded onto your computer and start using it without anyone saying that you're doing something wrong. So that's good.
Apologies, Dr. Greenhalgh, if I could stop you for a second. So unfortunately, we have had a few problems with the sound, so I know that a lot of our colleagues have said that they haven't unfortunately caught a lot of what you've said. I have now fixed the sound, and my sincere apologies to everybody for this. If I could, so what I did capture from what you said so far, so there's obviously changes in terms of the evidence that we've had, particularly around closing of consultations. You mentioned that some people had noticed that they felt that they'd been shut out the room effectively, but not in the room, just by closure of the consultation.
That was just one patient, but I think that patient rather captured the fact that,
Mm-hmm.
that a lot of patients are feeling that they haven't quite said goodbye to the doctor and finished what the consultation was about. Not because they were interrupted, but because those little rituals of ending the consultation hadn't happened.
And you definitely talked about this shift that we've had from going from chronic care type of video consultations to obviously the more acute care. I think those were the main points that unfortunately a lot of our colleagues weren't able to capture. So apologies if I could ask you just to go over that briefly again and then obviously carry on from there.
So which one did you want me to go over again?
So unfortunately, everything for the past 5 minutes or so they've not had.
I think the bit that I was saying last was the challenges of introducing video consultations in a GP surgery where nobody's done it before, and the standard pattern is the conventional face-to-face appointment with a bit of telephone, that kind of thing. I would very much encourage people to treat this as a kind of quality improvement / organizational change challenge rather than an exercise in installing a piece of software or a new piece of technology. And the reason for that is the technology is very often the easy bit. The difficult bit is all the infrastructural challenges of information governance, of getting the right committee or panel or board or whatever to approve it, which is often the GP partners in a GP surgery. dealing with things that say, well, our policy says something else, and that kind of thing. So I think so long as you treat it as an organizational change challenge, you've got a following policy wind. In other words, policy is falling over itself at the moment to stop patients coming to see you face to face. Everybody, Matt Hancock, Boris is up there today saying, don't have any kind of unnecessary face-to-face contact with anyone. Well, that specifically goes for doctors. So I think now is the time to grasp the nettle and have a go at this. But I would also underline what the slides said, that that actually this does appear to be a very safe, very safe and sort of standard way of consulting. It's not particularly different from what you would be doing with the patient face to face, so long as the technical connection is reasonably okay, and you've made the judgment that this clinical consultation is appropriately done through the video medium. And maybe we should talk a little bit more about that, Dr. Gandalf. What kind of patients should we be encouraging to consult by video rather than the phone?
I think that's definitely useful to talk about. So we've obviously got the, shall we say, the routine situation, which, as we talked about, chronic consultations and assessment-based consultations can be used. I guess right now we've got the coronavirus consultations, which are clearly different. So I know that you've done some work in terms of assessing which particular types of patients would be suitable potentially to be looked at via video consultation for coronavirus stuff versus I guess the routine kind of consultations. That document that you published a couple of days ago was excellent in terms of assessing that. Were you able to summarise that for us?
Talking to you the other day, somebody picked up and said, well, an A&E doctor said, we never use video because everything can be done by telephone, and if it's not the telephone, they need to be face to face. Well, I think that's changing that. It is absolutely true that the first port of call is either email or telephone, and you guys can tell me that you can deal with an awful lot of stuff by phone.
Yep.
You can now issue sick notes by electronic means, all that kind of thing, repeat prescriptions. You don't need to video people for that. Where it is useful is, first of all, when someone is incredibly anxious. Not just standard, I'm a bit worried about COVID, we're all worried about COVID, but the patient who really needs to make a visual connection in order to be reassured that they are seeing their doctor or nurse that they're familiar with. Secondly, you can do clinical assessments by video. You can eyeball the patient. You can see whether they look ill or well. You can assess the colour of their face, their rate of breathing. I watched a respiratory specialist nurse check someone's peak flow and also check their inhaler technique by video. Really nicely done. It was beautiful. The speech therapists do all sorts of interesting things with stammering children and children who need their voice trained and things like that. You can do a lot visually. So that if that's the case. What else did we say? I can't remember. I haven't got it.
And I think it's also the bilateral reassurance aspect that video imagery can give you. So often, so I've been doing telephone triage in our practice for about 3 years, and my bring down rate is approximately 40% of my patients that I telephone consult with will end up coming to the practice to see a clinician. And actually, out of that 40%, I'd probably say at least 10 or 15% out of that whole list in total, I'm simply bringing down just so that we can eyeball the patient, because I'm fairly confident they're okay, but I just want to eyeball, and it's particularly children fall into that category. So it's the extremes of the age, so the younger children and the elderly adults, where there is a lot more change that could happen. But often it is just simply to eyeball them. And the moment you walk through the door, often you have a good idea of how confident you were with your initial assessment. And you just need that visual check for yourself. But as you said quite rightly, it's also for the patient. It's that aspect that they have been seen. And simply that in itself is often a lot to reassure patients, not necessarily the examination, because you can take so much from a video interface in terms of examination. Like you said, respiratory rate is a good one that often is a good marker of how well someone potentially may be. comfort is another one I recommend, or directing patients in terms of examination. So actually you can examine quite a few joints just by instructing the patient, can you do this? Oh, actually I've seen you, for example, put your arm behind your back, so I know how good your internal external rotation is in your shoulder, for example. You know, how much movement have they got with their spine when they're complaining of back pain and stuff. And sometimes even just showing them something on the screen as well, you know, turning the camera around and saying, actually, can you do this? Or, you know, that kind of stuff.
Yes,
I've done that in a few.
we've done some research on this. I would absolutely agree with everything you say. There's an awful lot you can do, and often you have to. One of the things I was really impressed with watching the doctors and the specialist nurses when I went up to Scotland recently was new aspects of a clinical examination that I was never taught at medical school, because what you're doing is you're instructing the patient to do something that you would normally have done for them.
Yep.
You know, for example, putting on a blood pressure cuff. This was something I didn't know the patient could do themselves. I mean, obviously, you know, I kind of knew theoretically, but when the clinician is telling the patient, right now, you know, unwrap it, turn it round, no, you've got it upside down. So talking the patient through how to use pieces of kit. Now, they may have those pieces of kit at home, and if they do, it really helps for you to have one just the same, so that instead of just saying, well, turn it the other way around, you can actually model how you want them to shift it.
Mm-hmm.
So we had an example recently of a nurse who was trying to, she was in a heart failure clinic, and the patient had a pulse oximeter, and they'd got it wrong. They've got it on their finger upside down, and so the nurse was able to say, now hold it up, and here's my one, and then the patient turned it around and got it the other way up. So that kind of thing. But the other thing that's quite difficult is the patient has to take their camera and move their camera in order to show you the part of their body that is that they want you to look at.
Mm-hmm.
Now, some patients can do that, but bearing in mind that most of the time when you're doing a video to home, it's for someone who is perhaps elderly, they've got multi-morbidity,
Yep.
they're not very mobile. We've got some very interesting data on patients trying to show the doctor their swollen ankles and trying to get pitting edema. And some of them can do it, but most of them actually really struggle to, first of all, expose their ankle or expose their leg, and then to put the thumb down to do the pitting edema, but while also holding an iPad or a phone so that the clinician the other end can see it. And that is something, that's a trick that patients actually find difficult to learn.
Mm-hmm.
But I think this is small print stuff, because mostly, especially when you're doing COVID consultations, you're not particularly interested in their ankles. You just want to have a look at them breathing, you know, puff, pant, just like you can see me on the screen. You can tell that my breathing's fine and there's nothing much wrong with me. And you know, as Dr. Gandalf said, that's actually mostly what you're using video for.
Mm-hmm. And interesting, one of the other ones that I've sometimes done is to actually look at, for example, at the back of the throat for some patients. So if you can get them to have the spatial awareness of where to position things, actually you can then see things like, for example, the potential tonsils. Are you dealing with pus or not? Because actually a lot of patients can potentially do that. You're right, the elderly patients may struggle a bit more, but it's information that you've got useful. And then obviously if it's not, then the outcome is that you may still need to convert this into a face-to-face consultation. I think that's one of the things that you shouldn't feel bad about doing.
Do you ask them to put their finger on their tongue?
It depends on the patient, and so I tend to ask them to show me first, so I've got a rough idea of how good their Mallampati is, and if it's clearly going to be complicated, then I sometimes just leave it at that. If it's someone that thinks they can do it, I know that there is one of our anaesthetic colleagues on Twitter who famously showed how you can stick an iPhone into your mouth to have a look at your tonsils. I don't recommend patients do that. I'll be quite clear on that one.
Yeah, I mean, I went up when I was on the Outer Hebrides recently. I was met a couple of pre-operative nurses who were doing Mallampati scores to patients in a very remote hospital, using an incredible gadget which you could shine it down their throat.
Mm-hmm.
But it was connected. You know, it was on a wire, and it had a sort of a big magnifier on it, and actually you could see better down those patients' throats than I've ever looked directly. So I think if you have the gadgetry, but of course a patient at home, you know,
unlikely to
have an iPhone.
Mm-hmm.
But interestingly, how you can sort of do a crude pharyngeal examination. I've not done that myself.
Mm-hmm.
Certainly, you can do respiratory rate and that kind of thing. And of course, if the patient has a thermometer, you can talk them through the use of it.
Yep.
And you can tell them that they haven't got their mouth shut, or that kind of thing. So you can help them use the equipment.
So we've covered quite a few things about the types of consultations and stuff. I know, particularly with our current coronavirus outbreak and stuff, the acute assessment aspect of the consultation is going to be very much on the forefront of people's minds. Can you give people any tips or advice, I guess, in terms of I don't quite know how to ask this, but effectively the evidence about the assessments that they can do and the outcomes that might have? And is there anything that helps back clinicians up to say that actually you are potentially safe in doing it this way, rather than having to bring down every...
Yeah, it's interesting because I'm speaking at 6 o'clock tomorrow morning with a GP from Singapore who's been, Singapore had COVID before we did.
Mm-hmm.
He's got some data on the different, we're going to write something for the BMJ on how to assess COVID patients by video. And I was just looking at the data he sent me, and actually you can't, apart from the height of the fever, it looks like there isn't yet a kind of really good clinical risk score. If you say the patient's got this, and this,
Mm-hmm.
They're highly likely to have COVID, and if they've got that, and that, they're highly likely to have plain old flu. It doesn't look like it's that discriminatory.
Mm-hmm.
But I rather suspect that in 2 or 3 months' time, there will be a clinical risk score, and you'll be able to give them 3 marks for having something and 2 marks for having something else, and you'll add it all up and say, right, you're very high risk and
Mm-hmm.
that kind of thing. It's not there yet, or if it is, I haven't seen it, but I have been looking for it. So I think it's just a standard, clinical examination for a respiratory tract infection.
Mm-hmm.
And you guys know as well as I do that it seems that a very high fever is the one thing that
Yeah.
distinguishes this from a lot of other viral infections.
Yeah, so I think the three things that obviously they often comment on is that the high fever, the presence of a new onset cough, and the shortness of breath, I think, is the other one, isn't it?